I'm Brian Rini. I'm the Chief of Clinical Trials at Vanderbilt University Medical Center. So hereditary kidney cancer is, really, obviously separate and a separate topic from sporadic or non-inherited kidney cancer. And there are a few more common syndromes that you should be aware of. It's important to note that probably 95% of patients don't have hereditary kidney cancer. And so these, probably doesn't apply. We start to think about it as with any hereditary cancer when patients are younger, when they have bilateral tumors. In kidney cancer, there are guidelines for referral to genetic counseling, I believe, for any kidney tumor less than age 46 or 48, something in that range. So we pretty liberally refer suspected patients to genetic counseling, and I would encourage providers out there to do the same. Thinking about some of the major syndromes, the most common one, to my knowledge, would be von Hippel-Lindau syndrome. So this is an autosomal dominant disorder with dysregulation, inactivation of the VHL gene, the von Hippel-Lindau gene. It's most important in kidney cancer because it was this biology that really led to the discovery that that same gene is inactivated in sporadic kidney cancer. And all the angiogenic drugs we have are really based on that biology. But this is an autosomal dominant disorder where patients get multiple bilateral clear cell renal tumors. They get what I would describe as blood vessel tumors, hemangioblastomas of the retina, the brain and spinal cord, and some other tumors. And certainly can be challenging to manage. Most of the management is in the hands of the urologist. So observation until tumors get up to 3 centimeters, and then usually, partial nephrectomy or removal of that particular tumor. I think perhaps most exciting just in the last year has been development of the class of drugs called HIF inhibitors. So HIF is hypoxia-inducible factor. It's upstream from VEGF, and it's certainly relevant to the biology in these patients. And there was a study presented relatively recently by Eric Yonash from MD Anderson about the use of a certain HIF inhibitor in patients with VHL disease, and really dramatic effects. I mean, almost everybody had tumor shrinkage. It's also a really well-tolerated drug, and it's fairly devastating for these patients to undergo repeated surgeries, either on their kidneys or especially on their central nervous system. So I think there's real promise. That drug's not FDA approved for that or any indication yet, but I think there's real promise in managing these patients with HIF inhibitors in the future. The VEGF inhibitors haven't been as successful, and I've only managed a couple patients in many years with VHL disease with VEGF inhibitors. Just to touch on some other inherited kidney cancer, there's 2 types of inherited kidney cancer that can result in papillary kidney cancer, a separate histology. There's something called hereditary papillary renal carcinoma, or HPRC. It involves mutations in the MET gene. And there have been some trials of MET inhibitors that broadly have had, I would say, modest activity in sporadic papillary kidney cancer, but in germline or inherited papillary kidney cancer certainly have shown activity. Again, none to my knowledge is FDA approved in this indication, so still in clinical trials, but clearly a relevant biology. The other that leads to papillary kidney cancer is called hereditary leiomyoma renal carcinoma, or HLRCC. And as the name implies, it also leads to leiomyoma of the uterus and papillary kidney cancer. And these latter 2 are really also managed primarily surgically. So again, with multiple bilateral tumors, it's really a surgical approach to control disease as we hopefully try to develop better systemic therapy. And then last, I would just mention Birt-Hogg-Dubé syndrome, which is an inherited disorder that leads to chromophobe/oncocytoma kidney cancer. It also has fibrofolliculoma of the skin, and patients can get pneumothorax. And so again, even in 20 plus years of doing this, I've generally seen a handful of these patients, certainly many more VHL patients, as that's much more common. There are other inherited syndromes as well that are more rare, that I won't go into. But I think probably the take-home message is really just to understand when you see a young patient with kidney cancer in the clinic, especially if multiple tumors, especially if bilateral, especially if a family history, to refer that patient for genetic counseling, obviously for screening of other family members. And in the case of VHL patients, I should have mentioned to involve other specialists. So the neurosurgeon as needed for CNS lesions, ophthalmology, et cetera. So it's really a multidisciplinary approach to managing these patients.